Good evening, everyone. This presentation is brought to you by Group 38. Today, we will be presenting an important clinical case involving heart failure versus COPD. Let's get into the case. So, our patient is a 70-year-old male presenting with shortness of breath and bilateral leg swelling. His primary complaint includes worsening shortness of breath over last 2 weeks and progressive swelling of leg.
History of present illness. The patient presents with progressive dyspnea, which initially occurred with exertion but has now progressed to rest. They also report orthopnea requiring 3 pillows to sleep comfortably. There is history of bilateral leg swelling, which has been gradually worsening, indicating progressive edema. Additionally, the patient has experienced a decline in cough over the past year. Their exercise tolerance has also improved over the same period. Lastly, the patient has been taking over-the-counter diuretics but with minimal relief of symptoms. Next slide. Past medical history. In terms of past medical history, the patient has a long-standing history of hypertension for the past 20 years and has been on 10 mg daily. They also have chronic obstructive pulmonary disease for the last 10 years managed with tiotropium. Additionally, the patient has been diagnosed with hyperlipidemia for the past 15 years and taking atorvastatin. Importantly, there is no known history of heart failure, myocardial infarction, or diabetes. Next slide.
His social and family history: he is smoking 15 pack per year and trying to quit. He drink occasionally alcohol, and he take high sodium and low fruit in diet. A sedentary lifestyle due to dyspnea. And his father is a myocardial infarction at 68-year-old, and his mother is hypertension and COPD. And his vital sign is BP is 156/94 and heart rate 98, beat per minute, respiratory rate 22, breaths per minute, and SpO2 90%. And jugular venous distension at 8 centimeter above the sternum angle, and his abdomen is soft, non-tender, no rebound or gardening, positive hepatojugular reflex. And his respiratory diffuse wheezing, decreased breath sounds from the base level. And generally, his overweighted, fatigue, slightly diphoretics, bilateral pitting edema up to the knees, no sinus or clubbing.
Differential diagnosis. It includes acute decompensated heart failure, COPD exacerbation, and pulmonary embolism. Next slide. Acute decompensated heart failure. The primary diagnosis. Rule in dyspnea with orthopnea, bilateral pitting edema, jugular venous distension, hepatojugular reflex, elevated BNP 850 pg per ml, cardiomegaly, pulmonary congestion on chest X-ray. Rule out. No history of heart failure, normal troponin, absence of rapid weight gain.
COPD exacerbation contributing factor. Rule in history of COPD, smoking that is 50 pack years, wheezing, respiratory acidosis, PaCO2 48 mmHg. Rule out no recent URI, no fever, BNP significantly elevated such as the heart failure over COPD. Next slide. Pulmonary embolism less likely. Rule in dyspnea with hypoxemia, mild tachycardia. Rule out no sudden onset, no pleuritic chest pain, normal troponin, no signs of DVT, no Western marker sign on the chest X-ray. Next slide.
Next is diagnostic workup and results. ECG. On ECG, we observed sinus tachycardia and left ventricular hypertrophy, which are commonly seen in heart failure. Chest X-ray. The chest X-ray revealed cardiomegaly and pulmonary vascular congestion. Again, both are indicative of volume overload and heart failure. BNP. The BNP level was elevated at 850 picogram per ml, which strongly supports a diagnosis of heart failure. Troponin 1. Troponin was 0.01 nanogram per ml, which is normal, ruling out an acute myocardial infarction. CBC and electrolytes. WBC was normal, but there was evidence of mild renal dysfunction with a creatinine level of 1.4 and a burn of 28. This can be attributed to the heart failure-related congestion. Arterial blood gas. The ABG showed mild respiratory acidosis with hypoxemia. This is consistent with the patient's respiratory distress, possibly due to the combination of heart failure and impaired gas exchange. Additional physical examination for heart failure and volume status. Abdominal exam for hepatomegaly, ascites, and hepatojugular reflex. Bedside ultrasonography to assess IVC diameter and collapsibility for fluid status. Now coming to the final diagnosis and justification. Based on the diagnostic workup, the final diagnosis is acute decompensated heart failure. Let's break down the justification for this diagnosis. The elevated BNP level of 850 picogram per ml, along with physical findings like JVD, hepatojugular reflux, pulmonary congestion on chest X-ray, and peripheral edema, strongly point to ADHF as the primary diagnosis. Secondary diagnosis is possible COPD exacerbation. The presence of wheezing suggests a component of airway obstruction, likely due to COPD.
Management, acute management, oxygen supplementation to prevent CO2 retention, and diuresis like IV furosemide 40 mg to monitor unit, and we should monitor urine output and renal function, and the ventilation if partial pressure of CO2 greater than 50 mmHg or pH less than 7.3, and the bronchodilators for COPD patients, and the BP control. BP control, we use IV nitroglycerin if hypertension is present, and the atrial blood gas monitoring to guide ventilation and the acid-base balance. Next slide. Immediate ARDS management. We can check for ABCS and oxygen support, and we should treat the underlying causes for, like heart failure with diabetes, vasodilators, and for COPD, bronchodilators and steroids, and infection, embryonic antibiotics. And the hemodynamic support, we should avoid fluid overload, inotropes if stock is present. And monitor and reassess, repeat ABG, ECG and echo, ICU transfer if worsening. Next slide. Long-term management, heart failure, diuretics, beta blockers, ACE inhibitors, sodium retention, COPD, diatropy inhaler, smoking cessation, and pulmonary rehabilitation, and lifestyle management with low sodium diet, exercise, routine follow-ups, etc. Next slide.
Key points. BNP elevation more than 500 picogram is a key marker distinguishing heart failure from COPD exacerbation. COPD can mask classical heart failure signings due to airflow limitation. JVD and positive hepatojugular reflexes are strong signs of right heart congestion. Pulmonary congestion on chest X-ray strongly supports heart failure diagnosis over COPD. Diuretics are the cornerstones of acute decompensated heart failure treatment, but cautious is used in needed in COPD patient. COPD plus heart failure cardiopulmonary overlap syndrome is a common in smoker and should be managed holistically. Next slide. These are the references of our case. Next slide. These are our group members. Thank you.